Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 29th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the Adult Program Coordinator at the NSYMCA in Northbrook, Illinois. We are recording this evening's presentation so that you will be able to revisit it again. Please feel free to tell your family and friends about it so that they too can view it on either the IBJI or NSYMC websites down the road. Dr. Mehul Garala will be hosting tonight's program entitled Non-Surgical Treatment for Neck and Back Pain. According to the National Institutes of Health, 60 to 80% of adults will experience back pain, and 20 to 70% will experience neck pain that will interfere with their daily activities during their lifetime. Neck and back problems are pervasive and associated with chronic pain, disability, and high healthcare utilization. Back and neck pain can be caused by problems related to the spinal muscles, nerves, bones, discs, or tendons. The good news is that most spine conditions can be successfully treated with non-invasive techniques and without the need to resort to surgery. Tonight, Dr. Garala will teach us about the non-surgical options available to treat many back and neck ailments, injuries, and disorders. Mehul Garala, MD, is a double board certified fellowship trained physician specializing in physical medicine and rehabilitation, along with sports medicine, and has a special interest in non-operative spine management. As a practitioner of physical medicine and rehabilitation, he is commonly referred to as a physiatrist. Dr. Garala has extensive experience evaluating patients with neck, back, and other musculoskeletal injuries and comprehensively managing them through education, medication, physical therapy, and if warranted, administering peripheral joint or interventional spinal injections. He also has a depth of experience in occupational health and the management of workers' compensation injuries. Dr. Garala says that he is a non-operative, conservative specialist, so anytime a patient can improve without being referred to a surgeon is a huge bonus. His goal is to see patients improve and get back to a normal baseline. He is mainly a spine specialist, but has himself, he admits, experienced every musculoskeletal injury you can think of through lifestyle and playing sports and weightlifting, and so he feels like he can very often relate to what a patient is going through. And, he says, sometimes that's helpful in explaining their condition, overall prognosis, and in helping them to get better. Dr. Garala has a blog that has touched on topics such as what you need to know about back pain during pregnancy, avoid work from home pain, MRI misconceptions for back pain, and low back pain in the setting of COVID-19, which can all be found on his media page on the IBJI website. He received his undergraduate degree in cognitive science at the University of Virginia in Charlottesville, and subsequently obtained his medical degree at the Medical College of Virginia in Richmond. Dr. Garala completed his residency training in physical medicine and rehabilitation at New York Presbyterian Hospital, Columbia Cornell in New York City, where he served as chief resident. His rotations included other renowned institutions, including Hospital for Special Surgery and Memorial Sloan Kettering Cancer Center. Dr. Garala then pursued additional fellowship training in spine and sports medicine in Elmhurst, Illinois, under the tutelage of nationally recognized physiatrist Dr. Larry Frank. Thank you again for joining us this evening, and thank you, Dr. Mehul Garala, for your time and effort in putting together this program to help us understand more about non-surgical treatment for neck and back pain. Now, doctor, please take it from here.
Thank you for the wonderful introduction, Karen. Good evening, everyone. Karen, can you see my?
I sure can. Yep.
Perfect. So today I'm going to be talking about non-surgical treatment for neck and back pain. And the goals of the presentation is not only to discuss the treatment, but also to give some background information, anatomy, assessment, imaging studies, to give you the general context of what we think of when recommending a particular treatment. And at the end, I will do my best to answer any questions that the audience may have. So why am I giving a talk about neck and low back pain? As Karen alluded to in the introduction, they are very common. It is said that neck pain has a lifetime prevalence of 70%. Low back pain has a prevalence of 80%. And so it is a very common symptom and issue to have, and one of the leading causes for why patients seek medical attention. Now, a lot of people think that neck and back pain is simply due to mechanics of the spine. I was lifting something heavy and my back gave out, or I was involved in a motor vehicle accident, suffered trauma to my neck or my low back. And even though that is common, we are learning more and more that there are other factors involved. Obviously, there are mechanical components of pain, such as heavy lifting, twisting and bending, whole body vibration, prolonged postures, particularly of the neck, that can contribute. And there are other components of mechanics that we have to consider, including if there is trauma, age can play a role, as well as obesity, in which studies have shown that added weight can impact the low back. But we're also learning that there is a biopsychosocial component for the manifestation of pain. Biology pertains to the structures, the tissues, and how well they adapt to stress, and do they go back to their baseline. Genetics can play a role in that biology. The structures of the spine need to get their nutrients from somewhere, and so smoking can affect how they get their nutrients. And then there's also a psychosocial component. And what we mean by that is our emotions have a physical manifestation. And we know this when we get nervous. Sometimes our hands get sweaty. We get butterflies in our stomach. Or if we're embarrassed, for those that have light skin, we get rosy cheeks. So we know there are physical manifestations associated with our emotions. And so all in all, there's a lot of factors that can contribute to the manifestation of pain. From a structural standpoint, there are a lot of things that we have to consider of what is causing the pain. Karen alluded to muscles, bones, joints, disc, and nerves all can be a contributing factor. So to give a little bit of anatomy 101 to the audience, the spine is made up of 33 levels. We are broken down into 5 compartments of the spine. The neck is also known as the cervical spine and has 7 levels. The mid-back, also known as the thoracic spine, has 12 levels. The lumbar spine, also known as the low back, has 5 levels. The sacrum is the area around the buttock region, and it's a fused area of 5 segments. And the coccyx, which is also known as the tailbone, has 4 fused segments. Now, each what we call a functional unit of the spine is comprised of 3 joints. You have the disc, which is in between the bones of the spine. This is called they are called the vertebrae. And there is an interface between the disc as well as the bones called an end plate. These bones then form joints in the back of the spine called the facet joints. So a disc and a joint on each side of the spine comprises the 3-joint structure. The spine is one long tube from the neck all the way down. And so I describe it as the bones and joints create the outside part of the tube. And then on the inside part of the tube is where the spinal cord and nerves reside. So this opening where the spinal cord resides is called the central canal. And then at each level, you have an area where the nerves exits, and this is called the foramen. So all these terms that I am using are common things that we describe and discuss with patients as contributing factors or things that we look for when someone has pain. The neck, and I know this is a busy slide, has similar structure as to the lumbar spine, where it's a 3-joint structure where you have the disc in front and then the joints in back. Again, you have the central canal, which houses the spinal cord. Now, the lumbar spine sits on a fused bone, the sacrum. This is around the buttock area, and that helps form part of the pelvis. This area right here is called the sacroiliac joint, and this is the big joint in the buttock area that oftentimes can be a contributing factor for when someone has buttock pain. I wanted to show a superimposed picture of the nerves coming from the low back. You hear a lot of times people say, or practitioners say they have sciatica, a patient has sciatica or a pinched nerve. This is the area of the spine which is involved. Now, there are two main ways that someone develops sciatica or a pinched nerve. One is a herniated disc. Think of the disc as a jelly-filled donut, and the jelly has squirted backwards. Right behind it is where the nerve is, and so it can be pinched. In the top right-hand corner is a cross-section demonstrating that, in which the jelly has squirted out, and then it is pinching the nerve. Another common cause for a pinched nerve is arthritic changes to the spine, in which bone spurs and overgrowth of the joints can cause a narrowing. This narrowing of the foramen can pinch a nerve, and then also you can have, you can also have narrowing inside the central canal. This is called stenosis. It can be due to an overgrowth of the bone or a thickening of a ligament in the central canal, and this is called the ligamentum flavum. So when someone comes in with pain, there's a few things that we must entertain. The first and most important thing is the patient's history. There's different components, but the most important things that we look for are, is this related to an injury? Where is the pain located? And sometimes I ask the patient to use their hand to outline where they have their symptoms and if it travels. Is this an acute condition or chronic? Acute meaning, did this just occur within the last few weeks, last month, or is this a long-standing issue? What causes more pain? Does sitting, bending, standing, and walking contribute to it? Are there anything that makes the pain feel better or anything that makes it worse? And are there any associated symptoms? Now, I wanted to highlight certain yellow or red flags, as we call them. If any patient has these symptoms, it is advisable to seek a medical opinion or evaluation sooner than later. If someone has a history of cancer, particularly breast, lungs, thyroid, kidney, or prostate, the way I remember it is BLT sandwich with a kosher pickle, and they have pain at night that is keeping them up. We are somewhat concerned if there is a cancerous process that has spread to the back or the spine. If someone has back pain in the setting of fevers and chills, particularly in the event of a recent infection, sometimes we're concerned that there is an infection going on in the back. This is in particular concerning if someone is immunosuppressed or if they are if they use IV drugs. The other thing that we look for or ask our patients to monitor is if there is progressive motor weakness. If someone has a pinched nerve, the nerves are responsible in some aspect for the strength in our muscles. And so if a muscle becomes weaker and weaker, we are concerned that there is a more active compression of the nerve, and that might need more aggressive treatment. And then the last two, they are conditions that result in a constellation of symptoms and signs. CAUDA-EQUINA syndrome, even though it's very rare, is due to multiple nerves in the back region being compressed. And as I mentioned before, it can be due to a herniated disc or stenosis. When someone has CAUDA-EQUINA syndrome, they present with many symptoms, including back pain, weakness in their legs, numbness in their legs, sexual dysfunction, and the two most alarming things are usually bowel and bladder disturbances. It's normal as we get older to have some bowel and bladder issues, urinary leakage, but in particular, we're talking about the difficulty of controlling these organs. If someone has cervical myelopathy, it's a similar condition compared to CAUDA-EQUINA syndrome, but in the neck region where there's a lot of narrowing. Patients also can have bowel and bladder dysfunction, but they also might report dexterity issues, that things are dropping from their hands, or they may have balance issues. If someone has signs and symptoms concerning for CAUDA-EQUINA syndrome or cervical myelopathy, the treatment is surgery. There is no concerted treatment for those conditions. The next aspect of the evaluation of a patient besides the history is a good physical examination. There's a lot of components. Starts off with general inspection and the posture of the patient. When someone is presenting into the examination room, do they prefer to stand or sit? People that have a herniated disc, they have increased discomfort in a sitting position because it compresses the disc. So a lot of times they will prefer to stand. I will palpate and percuss the spine. If someone has a compression fracture and I sort of lightly beat up their back, they're not going to like that because that vibration is going to cause increased discomfort. I'm going to test the range of motion of their neck and their low back, and there's certain provocative maneuvers that we can perform that can give us clues of the etiology of pain. The other important aspect of the physical exam is a neurological exam. The nerves that come from our neck, mid-back, and low back usually travel in a certain pattern in the arms or legs respectively. And the nerves, as I mentioned, are responsible for the strength in our extremities, the sensation, as well as reflexes. So a lot of times when someone comes in with neck pain, we are testing their arm strength, their sensation, their reflexes to see if they can give us a clue in regards to the cause of their symptoms if a nerve is involved. And the same goes for the lower extremity as well. We perform diagnostic testing. A lot of times if you come in initially for an evaluation, we can readily perform x-rays, which are excellent at evaluating bones. So if we are concerned of an injury due to trauma or an elderly person that has bone health issues like osteoporosis, and we want to evaluate a compression fracture, those sometimes can give us valuable information. Other studies that are sometimes utilized are MRIs, which provide the best detail of the soft tissues, including the disc and nerves. A CT scan is a 3D representation of x-rays and the anatomy. Sometimes patients need to undergo advanced imaging study, particularly if those that cannot undergo an MRI due to a pacemaker. And there is another diagnostic testing called an EMG. It's a two-part test. The first part is NCS, called nerve conduction study, and the second part is electromyogram. And basically, it's an extension of the physical exam to test specifically for nerve injuries. And it's an extension of the exam that can sometimes help validate an injury coming from the spine or elsewhere in the peripheral nervous system. I wanted to briefly show you what we mean from these diagnostic studies. Here you see x-rays. The typical x-rays are AP and lateral views. This is of the lumbar spine, but we could do it of the neck and the mid-back or wherever we are concerned that there's an injury. Now, as I mentioned, x-rays are very good at evaluating bone. On the left, this is evidence of a stress fracture in a young adolescent. On the right, you can see a slippage of one bone over the other, so it can give us ideas of there's arthritic changes or other components of the spine that may be contributing to pain. On the left, this is an example of a compression fracture. The vertebrae look like rectangles, but as you can see in this, if I can use my pointer, sorry. As you can see on the left, one of the vertebrae looks squished, so that is the evidence of a compression fracture. And then on the right, even though it might not come up clearly, you can see these punch-out lesions, as I call them, where the density of the bone is not the same, and that is an example of metastatic disease to the spine. Now, the MRI is a common study that is ordered if we are worried about a pinched nerve. And as I mentioned, it gives very good soft tissue detail. And there's a lot of views that we perform to look at the side and the inside component of the spinal canal. You can tell on the left, this is a schematic representation of the anatomy, and on the right is a pretty accurate representation of the disc, the inside part of the spine, as well as the tissues that surround it. But I do want to stress a very common misconception about MRIs. MRIs are not pain studies, and I can't stress that enough. It is a detailed anatomical study of the area that we want to investigate. The structures of the spine undergo natural changes, just like we see normal natural changes on the outside of our body, like we get gray hairs or wrinkles as we get older. The structures of the spine do not stay the same shape and size, and things like bulging disc, arthritis, and stenosis are sometimes normal findings that typically show up on an MRI. And the older we get, the more common incidental findings are. There was actually a very comprehensive study that took people that had no pain whatsoever. And as you can see on this table, at the age of 30, 50% of the population is going to have a degenerative disc. At the age of 40, 50% of people are going to have bulging disc. And you can see as we get older, the more common these incidental findings are. So there is no one-to-one correlation based on what we see on the MRI and clinical symptoms. If anyone has ever gotten an MRI and they read the MRI report and there's some descriptions like severe arthritis, it doesn't mean that you're going to have severe symptoms. People that have small herniated discs can have severe pain, and people that have large herniated discs can be painless. So again, it's very important to interpret the MRIs with caution. I always say that we need to treat the patient and not the imaging study. And I use the imaging on the left as a point. Depending on the context of what you're looking at the picture, you can see either an old woman, in which again, I'm trying to use can't use the mouse at this time, but try to describe it. You can see either an old woman looking to her side, or you can see a young woman with her head looking backwards. And so again, depending on the context of what you look at the picture, it's very important because depending on the way that the patient describes their symptoms, their physical exam, it can definitely mean if there is supporting or incidental findings that show up on MRIs. So moving on to the main focus of this presentation, treatment. I say treatment is broken down into 5 standard categories, including observation, medications, manual treatment, mainly in the form of physical therapy, injections or procedures, and then lastly, surgery. But there are other treatments involved as well. Exercise can be helpful for chronic pain. People can use modalities like a TENS unit, which is sort of electrical stimulation. There is complementary and alternative medicine, such as acupuncture and chiropractor. A lot of people are in favor of acupuncture and chiropractor, but there is no solid evidence that it helps. So it's not a standard treatment that is typically recommended, but at the same time, if someone feels that it is helpful for their pain symptoms, I look at it as who am I to say otherwise. And there is also treatment to address the psychosocial components of the manifestation of the pain, like cognitive behavioral therapy and mindfulness. Now, observation is rooted in the fact that majority of pain symptoms do improve over time, particularly of the low back. 60 to 70% of low back pain recovers in 6 weeks and 90% recovers in 12 weeks, and that's if we did nothing at all. 40% of neck pain usually recovers over time. So if you have minimal symptoms, they're tolerable, it's not leading to any functional limitations, and you don't have any of the yellow or red flags, sometimes you can simply observe and see if the symptoms will naturally resolve. We recommend that patients modify their activities to whatever is tolerable. Unfortunately, there's no definitive position or posture that can be advised that will always prevent neck or low back pain. We do suggest to avoid bed rest. It's very easy when someone has severe back pain to be confined on the couch or their bed, but that has shown to slow down the recovery. So whenever you can, we want you to get up and move around. And also just put yourself in any position of comfort. So when you are sleeping, just find whatever position is comfortable for you. We get a lot of questions of the type of pillow and mattress that can be used. There is some evidence that medium to firm mattresses can be helpful, but it is not overwhelming evidence. So I don't want patients to spend thousands of dollars for a mattress and it turns out that it does not really help with their symptoms. Medications are often utilized, and the main goal is to reduce or eliminate inflammation, which is usually playing a role in the manifestation of symptoms. The two most common medications or classes of medications that we prescribe are either a steroid, mainly a Medrol dose pack, or non-steroidal anti-inflammatory medications. And there's a lot of examples. Obviously, Aleve and ibuprofen are the most common over the counter, but there are prescription strength. Now, with that in mind, there are always indications and contraindication of prescribing medications. A Medrol dose pack is a very strong anti-inflammatory medication that can upset the stomach lining, and it can also temporarily increase blood sugars. So if a patient has uncontrolled diabetes, it may not be the best medication for them. Also, if someone has very bad acid reflux or a history of a stomach ulcer, that is also a contraindication. NSAIDs as well usually affect the stomach lining, but long-term studies have shown it can affect the kidneys and increase the risk of cardiovascular disease. So we always want medications to be prescribed for a short amount of time. We don't intend it to be prescribed indefinitely. If someone has underlying heart disease, history of a stroke, kidney disease, again, those are contraindications sometimes of non-steroidal anti-inflammatory medications. In addition, they thin out the blood. So if someone is on a blood thinner, that also might not be advisable to prescribe. Other medications that are typically prescribed or recommended include Tylenol, which is great for pain, but it does not do anything for inflammation. Sometimes we prescribe muscle relaxants. We don't really know how muscle relaxants work, despite the name. I usually prescribe them as a sleep adjunct. A lot of times when people are having difficulty sleeping at night, a well-rested brain and mind can be helpful for the recovery. So we know that muscle relaxers do cause sedation. So a lot of times I prescribe that if I know people are having difficulty sleeping. There are other medications like nerve stabilizers that can be helpful. So if someone has signs and symptoms consistent with a pinched nerve, we often prescribe gabapentin, Lyrica, or Cymbalta. There is sometimes use of marijuana or CBD. We're still trying to figure out a lot of the evidence of what is the best way to use these medications. It's pointing along the lines that they are used for chronic pain and not acute pain. But because CBD oil in particular is not FDA regulated, we don't know the optimal dose, the frequency, or the form of intake. So it's not anything that has been stringently researched. And so we can't definitively advise patients to take it in a certain manner. And lastly, sometimes patients need opioids. We try to avoid prescribing opioids if we can. We all know that there is an epidemic in this country. And so for a short period of time, if someone has severe pain, we sometimes will bridge them until we can get their pain under control with other treatment means. I am big on physical therapy, and that's another treatment that I often recommend. The muscles around the spine serve as a guide wire and help stabilize it. And the way I look at the spine is there's a lot of things that we can't control. We can't control genetics. We can't control the age-related changes that naturally occur to the spine. But the one thing that we can always try to optimize are the health of the muscles around the spine. We can always work on the endurance, the strengthening component. So strengthening the areas around the spine, and you hear a lot about core strengthening, can help decrease the forces that are transmitted to the structures of the spine. And I always advise for, if possible, an individualized one-on-one program, because everyone is built different, and it's difficult to loop everyone that has back pain to certain generic exercises that they may see online. So again, I always stress, if possible and convenient from a logistical standpoint, a one-on-one treatment with a physical therapist. Now, moving on to injections. Studies have shown that injections can help reduce or eliminate pain, improve functions. In the regards of an epidural steroid injection, which I will talk briefly, it can decrease the reliance on pain meds. It also has a surgery sparing effect and is also cost effective. Now, with that said, even though we always wish for the best, sometimes injections do not work and the responses are variable. Injections can be repeated if necessary, especially if have been helpful for pain in the past. But we also need to realize that if an injection does not help, we need to reassess and see if there is a different type of procedure or injection that may be helpful. Now, the important thing to realize about injections is we need to inject the structure that is responsible for the pain. There is no one injection helps with all pain, and it's not simply, I hurt here, please inject the medication here. The analogy I use is someone has left-sided chest pain and they go to the emergency room and they also have jaw pain or pain going down their arm. If they go to the doctor and say, "Doc, my jaw hurts, can you just put a medication and inject me there?" They're missing the boat because the source of the pain is actually the heart. And the neck and low back is no different. Pain can be referred to different areas. So it is very important that we try to identify the structure that is causing the pain, inject or provide a treatment in that area. So the potential source of the pain is determined based on many factors. And as I alluded to, it's important to get a good history, perform the physical exam, correlate those findings with any imaging studies that were performed, and follow evidence-based medicine. A lot of research out there can help us determine what we think is the best injection or treatment. We cannot base treatment strictly on MRIs. So again, it is a very comprehensive evaluation that is needed. A few other things to note about injections or procedures: they are not walk-in procedures, unlike what you do if you come into our ortho access clinic with knee or shoulder pains and we can simply do an injection on the spot. They are called advanced imaging, or they're advanced procedures that require a special type of x-ray called the fluoroscope. We typically need insurance approval. For private insurance carriers, it's usually 6 weeks of conservative treatment that is needed and shown not to improve before they consider an injection. With Medicare, they came out with new guidelines as of last December that states that you usually need 4 weeks of conservative care. The other thing to keep in mind is these injections are mainly for pain purposes. If someone only has numbness that is not impacting their function, usually we recommend observation or nerve stabilizers. If someone has strictly weakness, no pain or numbness, then sometimes we just recommend continued physical therapy. Now, there are risks involved with injections and procedures, but they are minimal. The 3 things that I typically discuss with the patient are the risk of infection and bleeding, and this is simply because we're putting a needle through the skin. We minimize the risk of infection by sterilely cleansing the area. We use sterile equipment, sterile needles. The risk of bleeding is usually minimal because we use small needles, and we're not usually advancing the needles through any major blood vessels. However, with that said, there are certain risks or contraindications. If someone has an active infection, it is recommended not to proceed with an injection. And if someone is on a blood thinner, depending on the type of injection that is recommended, that might be a contraindication because we don't want to increase the risk of bleeding, specifically inside the spinal canal where there can be paralysis. And the last risk that is typically discussed is the risk of a nerve or spinal cord injury because needles are somewhat close to the spine. But that is minimized because we are using a specific type of x-ray machine. We are trained to identify the safety areas of where we can put the equipment or needles and where to avoid. The next 2 slides are pretty busy, but it's just to reiterate all the studies that are out there that shows the overall safety of these procedures. The risk of infection and bleeds are very, very small. A lot of the side effects that occur are simply due to the steroid or the anesthetic, and they are short-lived. So there's really no long-term sequela as a result of procedures that are done treating spinal pain. The other thing we have to consider if someone has a long-standing history of pain and they're not improving with medications and physical therapy, and we recommend injections, are what are the alternatives? Do we keep patients on medications? And what we are seeing is that long-term, if someone is on NSAIDs, as I mentioned before, it can affect the stomach lining, kidneys, increase the risk of a cardiovascular event. And so there are a high rate of death rates and hospitalizations. In addition, obviously, I alluded to the opioid epidemic in this country, and over 75,000 deaths occurred last year for people that are on opioids or narcotics. The other thing is, what are surgical options? And people, rightfully so, are concerned about, the fear of a surgical intervention. We also know that there's not always a guarantee that it will help with patients' pain, and there's a high cost of care. There have been studies that compared surgery to conservative care, especially in the form of a herniated disc. And studies have shown that herniated disc can be treated conservatively and can improve over time. In this particular trial, people that underwent surgery typically felt better more immediately, but when they followed the patients out over the course of years, it turned out that these patients got to the same endpoint. So if we can manage patients' pain and can ride out the condition, a lot of times people will get to the same point as their surgical colleagues or patients that underwent surgery. They also did comparisons between injections and surgery, and they found out that, again, injections can help with the pain and help patients avoid surgery if at all possible. Now, with that said, I have nothing against surgery. Obviously, I'm biased. I'm a conservative doctor, and I'll do everything my best, or I'll do my best to help patients and avoid a surgical referral. But sometimes there are indications for surgery. If someone has intractable pain and is unresponsive to everything that we're doing, medications, physical therapy, injections, sometimes surgery can be helpful. If someone has significant functional limitations and it's very important to be functional, then obviously, if they're a candidate, surgery may be helpful. Progressive neurological deficits, as I mentioned at the beginning, a yellow or red flag. If someone has more pronounced weakness that is continuing to worsen, and it's indicative of a more compressive lesion, then surgery is indicated to alleviate that compression. And then, as I mentioned, CAUDA, EQUINA, and cervical myelopathy are indications for surgery. There is no conservative treatment for either of those conditions. Now, I wanted to touch base on particular injections or procedures that we often do. The first four, epidural steroid injections, facet injections, medial branch blocks with the possibility of radiofrequency ablation, as well as sacroiliac joint injections, are common injections that we perform, and most of the pain management doctors at Illinois Bone and Joint can perform these. The last four are a little bit more specialized, and there are a certain providers that can do it, but not everyone is trained in doing it because they are more advanced procedures. Now, in regards to epidural steroid injections, facet joint injections, medial branch blocks, these are injections that or procedures that can address any aspects of the spine, including the neck, mid-back, and low back. The last four are usually in regards to the lumbar spine. KYPHOPLASTY and VERTEBROPLASTY, which I will discuss, sometimes can target the mid-back. So moving forward with describing the injections and procedures, as I mentioned before, they require a special type of X-ray machine called a C-arm or a fluoroscope. And this is a portable X-ray machine that can be rotated around the patient. In this case, the patient is laying down and the X-ray is right above them. And so we can maneuver the X-ray to get various pictures of the back, neck, or wherever we're targeting. You do need a skilled and trained professional, obviously, to do injections. One of the things that we need to be trained on is the human body is three-dimensional, but an X-ray image is two-dimensional. So we need to get different views to make sure we have an accurate placement of the needle. In regards to epidural steroid injections, which are the most common injections that are performed, there are certain indications. When people have, or a patient has a pinched nerve or stenosis, that may be an indication for an epidural steroid injection, and there's also other indications listed. Now, an epidural steroid injection is basically, we are putting the medication in the epidural space. This is the area around the spine and the nerve. And steroid is what we're injecting. So again, put all together, epidural steroid injection is a steroid, also known as cortisone, being injected in the epidural space. And there are three ways that we do this. We can either inject it from the side, which is called transforaminal, from the back, which is called intralaminar, or from the bottom, which is called a caudal epidural steroid injection. And they all have their indications and contraindications. Certain injections have more advantages over the other. And so again, I would encourage you to make an appointment with a provider to determine what type of injection can be helpful for your condition. Transforaminal epidural steroid injections are what research has shown is probably the best type of approach if you can perform it. This is an example of what we see on an X-ray. And so this is called the trajectory view. You can see that darkened spot is actually the needle, and it's right underneath what is called the pedicle. Now, based on our training, we know the outline of the spine and the nerves as based on this schematic. Again, X-rays tell us about bone. It does not tell us about where the nerves are, but based on our anatomy, we know where we can safely put the needle. And in this case, it's supposed to be right above the nerve. So we get different views of the spine using the C-arm. And in this case, we are advancing the needle right underneath the pedicle. And so this is a safety view, and followed by this lateral view, which tells us that the needle is right above the nerve and that opening called the foramen. Once we feel that the needle is in the proper location, we inject a contrast that helps outline the flow of the medication. And in this case, this is flowing inward, what we want to see. It's flowing along the nerve and into the spinal canal. So we know that if we then inject the steroid, it's going to follow suit. So an intralaminar epidural steroid injection is an injection from the back. You can sort of see here in the schematic that this is a direct posterior to anterior approach. Again, this is an X-ray showing that approach as opposed to the side that we proceed with when we're looking at doing a transforaminal. We verify different views that it's in the correct location. You can see the outline of the contrast, and then we administer the injection or the steroid. Caudal injection, as I mentioned before, is an injection from below. This is close to the tailbone area, just slightly above it. And we're trying to introduce the needle in a small opening called the sacrohiatus. And so you can see here that the needle is going through that hiatus or opening. We're verifying the location using different views, injecting contrast that shows a good outline that the medication is flowing up the spine, and then we're administering the steroid. Now, facet injections are usually indicated if someone just has neck or low back pain and does not have any signs or symptoms consistent with a pinched nerve. There is research that shows that when someone has neck pain, possibly facet mediated, that they typically follow certain patterns. In regards to the neck, there are 7 joints on both the right and left side. If someone has pain at the top of their scalp with associated headaches, we are thinking that sometimes it's the upper part of the neck that is involved. But if someone has pain along the trapezius muscle or in between the shoulder blades, sometimes that is pain referred from the lower joints of the neck. In regards to the low back, this is a little bit more straightforward. Studies have shown that it's the 2 lowest levels, L4, L5, and L5, S1, that are usually involved in the manifestation of back pain if you just have back pain and no signs and symptoms consistent with a pinched nerve. However, sometimes pain can be referred down the leg. So people think that they have a pinched nerve when in reality, it's just referred pain going down the back into the back of the hamstrings. So there are two types of injections when we are addressing facet-mediated pain. One is actually the application of steroid into the joints themselves, but there is another injection that we perform called medial branch blocks. So the facet joint injections are just like epidural steroid injections, except this time we are targeting the joints. On the right-hand side, you'll see the joint and the needle in that area in which we're injecting a steroid. And usually these injections can be helpful if someone has continued pain despite medications and physical therapy, and their pain has been ongoing between 4 weeks and 12 weeks. However, if someone has pain greater than 3 months, then they are a candidate for medial branch blocks. And that concept is pertains to the joints are innervated by two small nerves called medial branches. They are what send the signals to the spine and your brain that your joints are hurting. And so the concept is if we block those small nerves with an anesthetic, that your pain should be greatly diminished. And so it is a diagnostic injection where we inject an anesthetic and we give you a pain diary to assess if that helps reduce your pain. Now, we typically do 2 sets of these diagnostic injections, and each time we perform it, if it significantly reduces your pain, then you would be a candidate for what is called radiofrequency ablation. And again, this is an example of the low back, but the same holds true for people that have neck pain as well. If you are found to be a candidate for radiofrequency ablation, this is a procedure in which we put the needle in parallel to the medial branches. It usually is done at a surgical center simply because of the type of equipment that is used. The needle has to be put in parallel because the lesion is made in a sphere around the needle. And so what we're essentially doing is making a lesion to blunt the pain signals coming from the medial branch. And I know it sounds a lot worse when someone says it's a burn, but this is a very well tolerated procedure. Studies have shown that if you are found to be a candidate, radiofrequency ablation can provide longer lasting relief than any other treatment that is available if you do have facet-mediated pain. This is an example of the medial branch blocks that can be done in the office. Again, we're putting the needles perpendicular to where the nerves are and administering an anesthetic. And then this is an example of radiofrequency ablation where the needle is placed in theory, in parallel to where the medial branch blocks are. Sacroiliac joint injections are usually indicated if someone has a long-standing history of buttock pain. There are rheumatological conditions that can cause inflammation of that joint. In addition, that joint is sometimes involved if someone has pain after having a lumbar fusion, because that area sometimes gets stressed as a result of the surgery. Same concept, we're putting a needle into the joint. You can see this is the right side of the sacroiliac joint area in which we're administering a steroid. Now, I also wanted to take time to discuss these other procedures, kyphoplasty or vertebroplasty, Intracept, M.I.L.D, and the VERTIFLEX procedures. Kyphoplasty or vertebroplasty are indicated for someone that has significant pain due to compression fractures. Compression fractures, like other fractures in our bodies, can heal over time if the pain is manageable. However, there are certain subsets of patients that still have severe amount of pain. And so what is done is that a needle is introduced into the actual bone itself, and a cement mixture is placed in the bone. Kyphoplasty is where we create or put a balloon in, and it puffs up that area to create a cavity in which the cement is placed. Vertebroplasty does not involve the balloon placement, and so cement is administered directly into that bone. And this is an example on the x-ray of the darkened material is the cement mixture that is placed in the compressed fracture areas. Carson Daly is a well-known TV personality, celebrity, and he recently underwent the Intercept procedure. And a lot of it has been made in the news of this newer technology and procedure, and that's why I wanted to briefly mention that with today's talk. It is a newer procedure based on that. Research is showing that the vertebral end plate is now a source of, or found to be a source of pain. The vertebral end plates have a rich nerve supply, actually more than the disc. So more and more research is demonstrating that this is actually the area that can be a source of pain, and why fusions and disc replacements have failed patients, because they are addressing the wrong area of the spine. And this is predicated on the fact that the basiovertebral nerve is the nerve that is communicating pain to the body. So as I mentioned before, that the end plate is a cartilage junction between the disc and the vertebral body. And on the right, the yellow represents the basiovertebral nerve and all the nerve fibers into the end plates that can send signals for pain. And so the indication for the Intercept procedure is if someone has chronic low back pain, no signs and symptoms consistent with a pinched nerve, the patient should have failed concerted treatment for at least 6 months, and sometimes they undergo other injections like epidural steroid injections, FACET mediated injections. And there are certain descriptors on an MRI that can give us a clue that the end plates are involved, and these are called modic changes. And so this is an example that of modic changes. There are 3 stages, but in particular, type 1 and type 2 are associated with an increased likelihood that the pain is emanating from the end plates. So the Intercept procedure is a combination of 2 techniques that I just briefly spoke about, including kyphoplasty, where the needle is placed into the actual vertebrae, and radiofrequency ablation. So the needle is placed close to the vicinity where the basiovertebral nerve is, and then we create a lesion, radiofrequency ablation of that particular nerve. And so the key benefit of the Intercept is it's minimally invasive, it's an outpatient procedure, it's implant-free and it preserves the structures of the spine, and it does not alter the flexibility or the mechanics of the spine. And this is an example of the instrumentation. They're putting a wire into the end plate before they create a lesion. I wanted to lastly close with the M.I.L.D and VERTIFLEX procedure. M.I.L.D, which stands for minimally invasive lumbar decompression, and a VERTIFLEX procedure is indicated for people that have lumbar stenosis. Stenosis, as I mentioned before, is a narrowing in a lot of part due to arthritic changes. Someone that has lumbar stenosis would have back pain, leg symptoms, particularly fatigue or tiredness when standing or walking. And usually their symptoms resolve when they are sitting. So we allude or bring up the shopping cart sign. When someone has stenosis, they sometimes feel better hunched over using a shopping cart. But when they're standing upright, they actually feel more symptoms. And so again, it's a clinical diagnosis that is supported with CT or MRI findings. But the VERTIFLEX and the M.I.L.D procedure helps fill this treatment gap between concerted treatment, epidural steroid injections, as well as surgery. So as a lot of patients are thinking it's extreme to go from a steroid injection all the way to surgery, but until now, we didn't know really how to address patients. In addition, as we get older, we have more comorbidities, higher risk of surgery. And so this is now an intervention that can be helpful for patients, that can be helpful when they have stenotic symptoms. The minimally invasive lumbar decompression basically is indicated if the ligamentum flavum, which is again a ligament inside the spinal canal, is thickened. And the whole goal is to take bites or chunks of that ligament to open up the space again. And so this is a procedure where a special type of equipment is used, again, to sort of make bites of the ligamentum flavum. You inject contrast to ensure there is opening again. And so on the left, you can see the constriction due to that thickening of the ligamentum flavum. And on the right, after the ligamentum flavum was removed, you have a better flow of the contrast. This procedure obviously has a low risk profile because it does not involve any implants. You're removing a major cause of lumbar stenosis, which is the ligamentum flavum. It's an outpatient procedure. And another huge advantage, it does not preclude you from doing any other treatment in the future. So if it doesn't work, it doesn't mean then you can't undergo surgery if need be. The VERTIFLEX procedure is a little bit more advanced and has a little bit higher risk simply because you are putting in a device in the back. And it's almost like a car jack. And what you're doing is you're introducing a device in between the spinous processes to sort of open up the space in which the nerves exit the spine. Usually when we are standing or walking, the foramen is narrowed. So as I mentioned before, the shopping cart sign, people want to naturally flex forward to open up that space. And so the VERTIFLEX device is an artificial way to sort of promote that flexion at that particular segment. And this is sort of an example of an X-ray of where it is placed in between those bones. So I wanted to close by saying that every injection and procedure that we recommend has indications. They're both inclusion and exclusion criteria. Not everyone is a good candidate. I know people, there are people that have chronic pain and they're looking for any such way to improve their symptoms. And they say, oh, Carson Daly had this procedure. I want to undergo it as well. But as I mentioned, there are certain indications and things that we look for to determine if you're a good candidate. You need to be clinically evaluated. As I mentioned before, and I stressed that MRIs are not the sole determinant for source of pain or your treatment. And so you need to get your history, a good physical exam, and we need to correlate symptoms based on imaging studies that are performed. And then the injections or procedures need to be performed by trained specialists. The majority of the pain management doctors can perform what I call the bread and butter injections, epidurals, facet, sacroiliac joints. But not every pain specialist can perform those other procedures that I discuss. The Intercept procedure, which as I mentioned is a newer procedure, Dr. Dave Schneider at our Barrington office performs it, as well as one of our spine surgeons at our Morton Grove office, Dr. Thomas Gleason. The M.I.L.D and VERTIFLEX procedure are performed by Dr. Adam Young and Dr. Brian Clay at our Morton Grove and Des Plaines office. We're all trained in assessing patients. So if I see a patient and believe someone may be a candidate for Intercept, even though I do not perform the procedure, I will educate you about it and make sure you are referred to the appropriate doctor. So with that said, that concludes my presentation, and I'll open up to any other questions from the audience.
All right, thank you, Dr. Garala. That was super, super informative. Lots and lots of great information. We are right at 8 o'clock. I wanted to ask you, do you have a few more minutes to answer questions?
Absolutely.
Okay, terrific. I've got a question from Peter that asks, what is your opinion of inversion tables for alleviating back pain and disc compression?
Yeah, there's not any solid evidence that inversion tables work. Per research, you actually need tons of forces to distract the compression of a nerve. And so there's not a lot of solid evidence that biomechanically it helps. Now, it may help symptomatically, but also from a practical standpoint, the human body is made to stand upright. And so inversion tables may help temporarily when you're sort of upside down or traction is applied. But then as soon as you stop with the treatment, you're back to square one. So again, I'm all for anything that can help with symptoms, but it is not backed scientifically.
Got it. Thank you. Jay asks, are there any stem cell or other treatments to reverse or halt arthritis?
Yeah, that's something that I was thinking of including, and it's a very good question. So there are preliminary research that stem cells are showing promising leads, but the FDA, which sort of oversees stem cells application, there's a lot that we don't know about how to apply stem cells. Per federal guidelines, we are not allowed to manipulate stem cells. And so there is a lot of discussion of the proper amount of stem cells that need to be injected, how to procure them, and where to inject. And so right now, there is not anything that has been approved by insurance companies. So it is an elective decision. I think it all comes down to patient education and being well informed. I personally believe there's an ethical component at this time because there's not solid evidence that it helps. From my knowledge, stem cell injections in the spine are reaching up to $10,000. And again, it's an elective decision. And so I personally would feel very bad if I charge $10,000 and the patient comes back and says, oh, the injection did not help. And so I would just say if you have the means and you've tried every other treatment, then there's nothing wrong of getting an opinion. But again, the evidence is not quite there yet.
Got it. Thank you. Okay. Camille asks, what is the difference between a bulging disc and a herniated disc?
Yeah, it's a good question. So the way I describe a disc as a jelly-filled donut. And so if I press down on the donut, the dough bulges. That is what a bulging disc is. And bulging discs actually turned out to be normal findings that we see often on an MRI. It's like getting gray hair or a wrinkle. A herniated disc is basically when the jelly inside the donut has squirted out. So when someone has a herniated disc, there's a higher likelihood that it will pinch a nerve. But again, if someone has an MRI, there will be probably multiple levels of the spine that shows a bulging disc. And studies have shown bulging discs are not necessarily a source of pain, are just incidental findings that typically show up.
Got it. Thank you. All right. If someone has scoliosis that wasn't diagnosed when they were young that might be causing problems now, this is a question from James. He's wondering if physical therapy would be of value.
Yeah, so there's a particular type of physical therapy called the Schroff method that helps people with scoliosis. The thing is when we are adolescents and our bones are still growing, if it is growing to a degree that is causing more of a curvature, at that time, people will possibly undergo surgery. But when our bones are fully matured, the scoliosis curve doesn't sort of advance as much. But you're also at an age where surgery can't necessarily reverse the scoliotic curve. So you're looking at conservative ways of treating the symptoms. And one way is the particular Schroff method that physical therapy sometimes can help. You're not necessarily reversing the curve, but you're trying to optimize the muscles and the stability of the spine and the muscles around it, I should say.
Got it. Okay, thank you. And we'll stick with it with another youth question real quick, which is, should a 15-year-old with an apophyseal ring fracture, did that make sense to you?
Mm-hmm.
From weightlifting, continue weightlifting 6 months later? I'm guessing that's a concerned parent.
Yeah, it depends on clinically on how the patient is responding to treatment. I would say the number one thing that I always educate young adults and their parents is kids have immature bones. So when they come in with an injury, the first thing that we think of, is it a bone related issue? So if we have an adolescent that has back pain, the first thing I am thinking of is a stress fracture. With adults, it's more of a muscle related issue or something non-concerning. So I'm actually more aggressive in working them up, maybe getting an MRI to assess for a stress fracture to their back. The apophysis ring, again, it's a good question, but it's difficult to answer. It just depends on, one, are they clinically healed? Are they feeling better? Are they asymptomatic? Their physical exam, are they demonstrating good range of motion? Provocative maneuvers are unremarkable, and if they accomplished all their goals with physical therapy. And that's what I personally use to determine if a kid is able to go back to sports or weightlifting. Is they need to be as asymptomatic as possible, need to have a normal physical exam, and they need to meet all their goals with their physical therapist. And if they do, then I usually will allow them to return to some sort of activity.
Great, thank you. That was really helpful. Sherry asks, what is piriformis syndrome and how is it treated? And is this a form of sciatica?
Yeah, piriformis syndrome is a thing that is commonly brought up in social media, but it's actually a rare condition. The nerves that come from the back, and that's why I brought up this slide of the pinched nerves. What people describe as sciatica is actually a pinched nerve coming from the back. But truly piriformis syndrome is the nerves that come from the back sort of form together to create a large nerve called the sciatic nerve. And this nerve goes through the buttock muscle, the piriformis. And so a lot of times people think when they sit down, they have symptoms going down their leg, and they're told that they have piriformis syndrome, when in reality, their symptoms are coming from the back. So it's very difficult to tease that apart, but research shows that piriformis syndrome itself is actually really rare. And really the treatment is physical therapy for that. You're trying to decompress the muscle, the piriformis, so it's not pressing on the sciatic nerve. There's really not a good injection. Rarely is surgery indicated. So again, it's very important to get evaluated for the practitioner to do a physical exam to truly determine if you have piriformis syndrome. But again, a lot of times people are told that they have piriformis syndrome from social media, physical therapists, chiropractors, but really it's a pinched nerve coming from the low back.
Got it. Thank you. That, again, very helpful. Deborah asks, would a steroid injection in my neck possibly alleviate the pain, numbness, and tingling down my arms and into my hands?
Yeah, so what you're describing is the possibility of a pinched nerve coming from your neck. And so, as I mentioned, to determine if it may help, we need to get a more appropriate history, correlate it on physical exam, and see if there is supporting evidence of a nerve being pinched in the neck, and also determine what you've done from a treatment standpoint. There is a possibility that a steroid injection into the neck can be helpful. It just depends if there's an indication.
Got it. Thank you. Camille asks, if you're allergic to contrast dye, could you do an injection without fluoroscopy?
So a couple of things. If you're allergic to contrast dye, there are a couple of ways that we work around it. One, we can give you a prednisone sort of medication to take before the contrast to minimize a reaction. But then there is also a non-iodine contrast called Magnavis. So if you truly have an allergy to contrast, usually it's an iodine-based solution. There is another type of contrast that can give us a good amount of outline that does not involve iodine. And so those are ways that we work around it. Sometimes if we're very confident that the needle is placed in the proper position, that if need be, we don't necessarily always need to inject contrast. It's advisable because it can tell us the correct placement. Sometimes the injection can go into a blood vessel, which we want to avoid. So we always try to inject contrast, but as I mentioned, there's certain ways that we can work around it.
Great, thank you. She also asks, are TENS units effective? She thought they weren't used anymore, and she's wondering if they're still something that are used.
Yeah, so that's why I branched that into the other category. There's not any science behind it. It follows what is called the gateway theory of pain. And briefly, an example is if we are cooking on a stovetop and we burn our hand, and what we naturally do is we try to rub it, okay? And so the nerves that are responsible for pain are slow, unmyelinated nerve fibers. When we have light touch, those stimulate nerves that conduct a lot faster to our spine and our brain. So our brain sort of overpowers the pain fibers because we're stimulating the light touch. So
Gotcha.
attention is the same principle. Where someone has pain, we're trying to mask it by stimulating sort of the larger nerve fibers. And so there is some utility, not anything that has really been backed by science. I've had a patient recently that has used a TENS unit and she feels like it's very helpful for their pain symptoms. And so it's just another adjunct treatment, but not something that is standardly recommended.
Okay, thank you. That's again super informative. Fred asks, is there any empirical evidence that PRP or platelet-rich plasma can be a useful treatment for lower back pain?
Yeah, so they are doing research about PRP. It's along the same sort of level of stem cells. And so there is preliminary research. Some of it is promising, some is actually inconclusive. So not anything that we can definitively recommend. Again, PRP is considered right now an elective procedure for those that are performing it. I do not believe any of our pain management doctors are performing PRP injections to the spine.
Gotcha. Okay. And Sherry asks, in addition to the exam and x-ray, when someone's being diagnosed with sciatica, is an MRI usually indicated as well?
It all just depends. Very good question. I look at it is in the fact of, is it going to change the initial management? When someone has pinched nerve symptoms, the initial treatment are medications and physical therapy. So no matter what the MRI shows, it's not going to change that initial treatment. So I always say, let's say we did get the MRI and it confirms that you have a herniated disc and pinched nerve. First line of treatment are medications and physical therapy anyways. Let's say we get the MRI and it doesn't show a pinched nerve. Well, the patient still has pain symptoms. First line of treatment is still medications and physical therapy. So a lot of times an MRI is not indicated initially, but if a patient does not improve over time, then we're looking at the next step, which is basically injections. And so you do need an MRI, one, to give supporting evidence that a nerve is pinched, but it can also give us information from a planning perspective, because where that nerve is being pinched, we're going to then try to put the medication directly in that area.
Gotcha. Great. Thank you. And Mindy asks, if after an ablation and having buttock pain and hip pain, would you need an injection possibly in that area, or would you like think back to the spine, I think is what she's asking.
Very good question. Yeah, it's both of those are possible causes. I mean, back pain can refer into the buttock area, or the buttock region can be a source of pain. And so I describe that area as like a gray zone. When someone has pain just right above the buttock area or low back, pain can be emanating from the lumbar facet joints or the sacroiliac joints, or possibly both.
Got it. Okay. Thank you. And I think this will be our last one because we're hitting 8:15. For someone who has blood clots and can't use NSAIDs, do you have a recommendation for them for pain relief from arthritis in their back?
Yeah, it's difficult. So definitely NSAIDs are contraindicated if you have a blood thinner. A Medrol dose pack may be helpful because that does not thin out the blood. And then you're looking at the other treatments, Tylenol, nerve stabilizers if we feel that there is a pinched nerve involved. If the pain is very severe, again, as a bridge, sometimes opioids, which we tend to avoid. but that's also why it's probably important for physical therapy also to be implemented. I didn't stress this before, but the number one goal of physical therapy is to try to reduce the pain. So there's people think there's a contraindication. Oh, I'm in so much pain, I can't do physical therapy. But really, physical therapy's number one goal is to help reduce the pain.
Great. All right. Thank you, Dr. Garala. Your time was greatly appreciated, and you know, we can't thank you enough from the Y and on behalf of everyone who was here this evening. Appreciate all of your input and taking the time to answer all of our questions as well. Have a great evening, everybody. Thanks, Dr. Garala. Thanks, everybody, for joining us.